Hey, welcome to BC Nephro. Thanks for watching. Back outside today on this beautiful day to talk about Membranoproliferative Glomerulonephritis, MPGN. This is a condition that is next in our series of proteinuria nephrotic syndrome. To check out an overview, check out the video on this channel, or check out the article at bcnephro.com. Links to both will be in the description below. So even though this is talk about listed under nephrotic syndrome, there's a wide range of presentation. So it can present as nephrotic syndrome, it can present as subnephrotic proteinuria, it can present with more of a nephritic picture with glomerular hematuria and subnephrotic proteinuria. It can present with a rapidly progressive glomerulonephritis, or it can present as part of a systemic vasculitic syndrome. So wide range of presentations and wide range of etiologies that we'll also get into. So first of all, membranoproliferative glomerulonephritis. What is it? So membranoproliferative glomerulonephritis, MPGN, is a pattern that is seen on the light microscopy of kidney biopsy. So membrano means that the glomerular capillary walls on the biopsy are thickened. This is like in membranous nephropathy, thickened glomerular capillary walls. Proliferative means that there's an increased number of cells in the glomeruli that cause the inflammation. Think about a proliferative lupus nephritis. Membranoproliferative glomerulonephritis has a combination of both these things: thickened capillary walls and increased number of inflammatory cells in the glomeruli. Now, there's a wide range of causes, and the cool thing about this condition, the immunofluorescence of kidney biopsy, can help you understand the pathophysiology that's causing this specific condition, and also help lead to the appropriate and correct diagnosis. So the immunofluorescence on kidney biopsy typically stands for 5 things: 3 immunoglobulins, IgA, IgG, and IgM, as well as 2 complement, C3 and C1q. So you can see any combination of these things on the immunofluorescence. So first, if you see immunoglobulin dominant, so most often IgG, often with C3, but sometimes without, you're going to think about an immune complex glomerulonephritis. So there's a number of causes of the immune complex glomerulonephritis. One of the most common things is infections. In this case, particularly hepatitis C. Hepatitis C, cryoglobulinemia, causes those immune complexes and show up on the kidney biopsy like this. Rheumatologic conditions can cause this as well. One thing to think about is Sjogren's syndrome, in addition to lupus and rheumatoid arthritis, can cause this presentation as well. Now, sometimes the immunoglobulin will be not a polyclonal IgG like you would see in hepatitis C. It would be a monoclonal due to a monoclonal gammopathy. Could be fully blown myeloma or B-cell lymphoma, or could be just a monoclonal gammopathy of renal significance that is causing this problem here. Now, another possibility of what you can see on the immunofluorescence of kidney biopsy is you don't see the immunoglobulin, you only see the complement. So if this is a case, you're thinking about something called C3 glomerulopathy. And C3 glomerulopathy can be caused by a couple things. Sometimes these monoclonal proteins, the monoclonal gammopathy renal significance, can cause this presentation as well. But there's also a whole host of complement disorders, like the ones that are associated with atypical hemolytic uremic syndrome, factor H, factor I, C3 nephritic factor, all these type of things can cause this C3 dominant picture. Now, another possibility is the immunofluorescence is essentially negative. You don't really see anything. And that can give an MPGN pattern, and this is seen in thrombotic microangiopathies or hemolytic uremic syndrome. So this understanding of what you see on the immunofluorescence is going to lead to your evaluation, checking for hepatitis C, Sjogren's, monoclonal proteins, or these complement disorders. One important clue to lead you to think that MPGN is a diagnosis is low complements, particularly a low C4. So if the C4 is very low, you're thinking this, and you're going to be checking for hepatitis C and cryoglobulins and things of that nature, the things to lead to this differential diagnosis, and you're going to be thinking about doing the kidney biopsy there. So the treatment is going to be really dependent on which clinical presentation you see. If you see a clinical presentation with proteinuria and either a normal stable creatinine or the creatinine is already burnt out and the GFR is very low, a lot of scarring, tubular interstitial fibrosis on the biopsy, you're going to be thinking supportive care. You're going to be thinking renin-angiotensin system blockers. If you see a nephrotic syndrome, nephrotic proteinuria, you're going to be thinking about that type of treatment. So you're going to be thinking about glucocorticoids. Maybe if those don't work or the creatinine is worse, then you're going to think about adding immunosuppression like mycophenolate, Rituxan, or cyclophosphamide. If you see an RPGN type picture with the creatinine going up, you're going to be thinking treat based on this, which is typically pulse steroids followed by oral taper and oral cyclophosphamide. If you see the C3 glomerulopathy, those can often be responsive to MMF, but if you diagnose some sort of complement disorder, you're going to be thinking about eculizumab for the treatment of that. So that's it. Membranoproliferative glomerulonephritis, which is can have a wide range of presentations, and the pathophysiology on the immunofluorescence can lead you to the appropriate diagnosis, and the clinical syndrome with the appropriate diagnosis can lead you to the appropriate treatment. If you like this video, like it, share it with your friends, and some people, if you think someone else might benefit from it, share it with them. For more information, visit bcnephro.com. For questions, leave them in the comment below or email me at brian@bcnephro.com. Until next time.